Thanks very much. Really nice presentations. My question's for Leo. Do you routinely monitor the dynamic transpulmonary pressure in spontaneously breathing patients with ARDS? And if you do, how do you account for the resistance component of the pressure when you're assessing the effort level?
No, well, the first part of your question, the answer is no. It's not routinely. We tend to do it more and more. We're using the esophageal catheters, the esophageal balloons more and more, but it's not routine right now. So it's in selected patients, difficult to wean patients, or these kind of patients, patients with ARDS, with spontaneous breathing effort, where the clinical indication is that they have a very high respiratory drive. And I think by using these parameters for a scientific reason is a little bit different than using them for a clinical reason. I mean, for a clinical indication, I think it's important to know if the changes in esophageal pressure are 20 or 5. And it's not that important if it's 20 or 21 or 22, I guess. So for a clinical indication, I will discuss that in a little bit more detail tomorrow. The exact value to me is not that important. I just want to confirm that the drive is extreme and it's something I need to do.
I think the two other speakers could also address this question.
Right. It's not very. Yeah, I don't think there is a very simple answer to this question. I mean, I don't know what I can add. I mean, in terms of sedation, you wanna.
Or measuring the transpulmonary pressure and taking into account the. You routinely do that in your patients?
No, we don't do that in our patients because I think it's interesting, but it's yes, of course. But what information will you get? It will be maybe too high, and then you will say, okay, in case of double triggering, for example, we have double triggering, so there is a lot of asynchrony, and we have a high transpulmonary pressure, and then we will be more likely to resedate the patient. That could be an answer. So it could help us if there is a patient fighting the ventilator and we have a high transpulmonary pressure, then it could be interesting to resedate the patient. But we don't do it in routine. We don't do it in routine. No?
May I ask my co-chair to comment on that also? Do you routinely monitor transpulmonary pressure?
We try to use it more and more. It's clearly not routine. I just will comment a bit later on the Papazian study about neuromuscular blocker. We all love to have patients spontaneously breathing, and we were really shocked to see that giving neuromuscular blockers improve survival, which means that there is something wrong which we do not see, which we do not appreciate about bad patient-ventilator interactions. So I really think we should do more and address these complicated questions, but seeing as in your first schema that a patient is doing -15, -20, I think it's a very, very important clinical information that today we ignore.
Yeah, maybe what we need, what we need is some little more simple, balloons and sensors and the tool that we have today. They are a little bit complicated to use, and maybe we need some improvement of the equipment we are using.
Sure, we have 3 questions. So, 4. So okay, we'll miss the appetizer. But it's okay.
I just wanted to. It's a question for Leo Heunks. I just wanted to ask a practical question. You had eight patients in your study. How long did you give your neuromuscular blockade?
So for the total time, it would be a bit more than 2 hours.
Yeah.
So the titration is a few minutes and then 2 hours
and did you prolong the treatment after that? If you
No,
saw
we did
the-
not. No, and that's not the message. I think the message right here, I want to be very clear, is that you can't do this today in a kind of clinical routine. It's a proof of principle that we can you can reduce respiratory drive by a huge amount of sedation. But there's another way, perhaps, and not today for clinical routine. It's, again, a proof of concept that you can reduce the respiratory drive by a low dose of a muscle relaxant. But that's the goal of the study. So, I mean, I have to be honest, like I said, I mean, the titration of rocuronium is not easy. You need a doctor all the time to increase the level of your muscle relaxant, decrease the level. Otherwise, you completely lose your respiratory drive. So the drugs we have today are not suitable for this, well, for this treatment. It's just a proof of principle.
I guess, Leo, I had a question for you, and you in a sense answered it. Because I think if you think about spontaneous breathing, it's really not ventilator-induced lung injury, it's ventilation-induced lung injury. And the study from Mascaroni in 1988 in sheep showed that if you increase their drive sufficiently, animals spontaneously breathing could give themselves ventilation-induced lung injury. So, but I was going to ask, in your study, it's very interesting data you've got. How would you extrapolate that? What kind of study would you do to actually prove that it decreases ventilator-induced lung injury? Because it's a very difficult study to do. You're not going to do a mortality study, presumably. Do you have any ideas of how you would actually go to the next step to show that this might be clinically useful? Because these patients are very difficult. Patients who have very high tidal volumes, even spontaneously breathing, and with acute lung injury, like, what do you do with them? So what do you suggest going forward?
I don't want to suggest too much, I guess, but no. I think the most obvious thing would be to look at inflammatory markers in the lung. That would be more or less the easiest way to go. If you have an inflammatory marker with a short half-life time that's very responsive, that would be the easiest way to go, I guess. What I can tell you, what I would be very interested in is, and it's too early right now, if we try to reduce the level of sedation, right? I mean, this has been done in healthy subjects, and they were actually fine. You reduce the maximum inspiratory pressure from 100 to 10, and they were still breathing. So what if we could do this in our patients? So we even reduce the level of sedation, so we don't have to give the sedation for controlling tidal volume or controlling patient-ventilator interaction, but it's just a little bit of sedation, patients are more awake, and if the drive's too high, this is just what we use. But I think that's for the faraway future. It's just the idea.
Yeah, thanks for this great talk. I just have another question about the Pendelluft. Besides that, I like the German word for it.
Sure.
The authors showed that that Luft cycles between zone 1 and 4, and that we can generate, that tidal volumes of 50 mils per kilogram are generated. But let's say in our ARDS patients, or in many of them, there is no zone 4. It's not recruitable. Zone 3, barely recruitable. So there is not very much Luft to pendle. So is the effect that these authors show not simply in these healthy pigs and in an ARDS, in the baby lung, there is not enough Luft to really cause villi then? So is that an effect of in a healthy individuum and doesn't count for ARDS patients and can't explain Papazian then?
I think the way I presented it was a kind of simplified way to show it in a few minutes. As you are aware of, ARDS is a very heterogeneous disease with areas in the lung with high compliance, area in the lung with low compliance, airways with low resistance, airways with high resistance. So even in zone 1, there's definitely Pendelluft from the left to the right side if there's a difference in lung mechanics. And I didn't have the time, but there is a fantastic paper in JEP at 2014 that describes all the physiology behind the Pendelluft. So I don't think it's necessarily from zone 1 to 4, but it could be from left to right as well.
I would like to ask Alexandre about ineffective effort during expiration. Okay. Ineffective effort during expiration is a type of lengthening contraction of the diaphragm, meaning that the diaphragm contracts and the volume decreases. And we know from exercise studies that lengthening contraction actually damages the lung. And this effect lasts for a lot of time after the contraction. Do you have any idea, or do you know any study that address this issue on diaphragm regarding ineffective effort during expiration?
No, I don't see any study that have, you mean specifically studied this type of ineffective effort. No, usually
because I don't know. I mean,
you know what I know is that they're all pooled as one type of ineffective effort. Either they happen during expiration or
But
yes.
If I understand your point, because you were saying we don't know whether it's patients are not dyspneic, so
No,
we don't. Maybe we are not too concerned, but maybe that's very bad for the muscle itself. So
yeah, maybe. No, maybe, but
maybe it's a model of really the worst possible contraction for the diaphragm, even if it's not strong effort.
But
yes, no, that's a good point. But we have no evidence for that, and if we get completely rid of this asynchrony, this effort, and maybe they're good for the diaphragm also, because maybe there's a kind of training of the diaphragm. You know, the diaphragm is still contracting, and maybe it's good for diaphragm fibers. So we don't really know. That's the whole point. We don't know. Maybe they're good. Maybe they're bad. Maybe they're nothing. So
I think we need to study this. I think it's important issue.
Sure.
First, a comment on the previous discussion. There is actually a study from Montreal when we were there, which actually looked upon eccentric contractions of the diaphragm, and they are injurious. They damage the muscle. They were very violent eccentric contractions, I would call them, but they certainly do damage to the muscle. That's no doubt about that.
Can you use the microphone, please?
There is definitely the diaphragm actually, you may produce damage in the diaphragm, and there are studies in rats showing this. My question is if there is a study addressing ineffective effort during expiration and diaphragmatic damage.
And that's what I just said. There is. So the other question I had was, first Hadrien, which did a very nice study to show how sedation actually, similar to I think Navalese's group showed also with propofol, how it reduces the actual effort of the patient and the drive without affecting so much the respiratory rate. And we saw, in the previous Congress, we had Navalese present data, which has not yet been published, where they show that giving morphine instead slows the rate, but actually increases the effort. And I think in this case, where Alexandre shows two very important desynchronies, we missed one, which is the one where we have no effort. And I would go between Leo and Hadrien and say, we usually over-assist today. That's the biggest problem. These patients are very exclusive, these guys who are pulling so hard that you can't turn them off. The majority of patients are really over-assisted. So could you please comment on that between yourself?
On the no effort, the patient with no effort. So you mean those who just trigger the ventilator and then are passively inflated? So yes. So that's I think that's a big issue for the diaphragm, because then the diaphragm is resting, and it's not very good because it causes ventilator-induced diaphragm dysfunction. Probably, we think so. It's not. There is no strong evidence, but there is a little evidence for that. So in general, in these patients, there is also ineffective effort that appears. And I think that if we decrease a little the level of assistance, then these patients, we will not generate. There's so much assisted that if we decrease a little bit the level of assistance, we will not generate dyspnea, but we will generate effort. So that's what I will suggest.
It's a brief addition on that, because Well, we're doing quite a lot of monitoring in our ICU patients right now, either EDI or the esophageal balloons. And that's the first thing that we started to learn, that even if patients are on just 12 or 10 of pressure support, and Jennifer showed a couple of pictures earlier, we were quite surprised that, well, I always thought that 10 of pressure support is a rather low level of assistance. Quite a lot of patients were indeed over-assisted and didn't have any EDI activity at all. So I think, and it also shows that monitoring in itself may not be, to start out with, extremely complicated. And I agree that there are a lot of physiological drawbacks. You have to be careful with interpretation of the data, but determining whether a patient is breathing or not is not that difficult. That's really easy, either with the balloon or the EDI.
Okay, we're about 15 minutes delayed, so I think it's a duty to close the discussion here. Please do not hesitate to continue the discussion during the break.